All right, so tonight, obviously, we're going to go over trauma. I wanted to just touch off some things. I don't know if many were able to see some of the updates that I posted on our page, so I can turn around and um, kind of pass it out to everybody. Not real sure. I'm still learning the canvas, but y'all have probably seen there's been a lot of changes in the canvas. I don't know if it notifies you every single time or what when I do something, but I have gone through there and we have a lot of people that haven't caught up. So what I've done is I've given them deadlines. I've given them um, deadlines to catch up, or they're going to be out of the class. Same thing with some of the classes coming up. The classes that we haven't gone over, I have locked it. It will become available on certain days. I'm not saying don't go ahead. By all means, please read ahead by the next chapter. If we're done with something, please read ahead. But what I've done is I've limited the the classes, and instead of all their chapter quizzes and all that being unlocked, I've locked them all. Just to kind of inform y'all too, from way that I can see on my Canvas site, that we've just completed a module. So you should be coming up to have taken the test, or you should have already taken that. I'm actually clicking on it right now to see a lot of some of the grades on 3, wherever it's at. Yeah, so far, um, only a couple of you have taken the module 4. Um, it appears that it's been kind of hard. But if you need any questions, if anybody has issues, or y'all want to talk about something, let's talk about it before you take that test, and we'll move forth on that one. But y'all let me know. You're actually probably gonna try to change a few things coming up. So I'm not preventing things from getting started. I'm just saying we are. If y'all have any questions, we haven't finished 3 yet. See, I don't know, Travis, because on mine, when I look at mine, it shows chapter 3 closed with chapter 23 quiz. Well, we're starting chapter 24, so my this is now a new module 4. Uh, yeah. So medical was one. Now we're starting trauma. Trauma will go until module 31, and then module 5 is only 3 chapters deep, and then you get the big final. So um, I've looked at several things in the chapters. I attempted to look at the final today, but that didn't happen. So that's it. If anybody has any questions, please message me on the side. We can set up a time or whatever to um, conference call with each other, and the class coordinator. If y'all have any other questions, she can also help. Rob's super busy. That's the reason why I'm not trying to exclude him by no means, but he's being pulled in about 500 different directions plus his full-time job. So I've talked to the class coordinator a lot. She's awesome. She may teach one of our classes one night just because I have something on the books that I may not be able to make it to a class, but we shall see. All right, so tonight we're going to go over trauma. Since this is our new fun topic that we are starting, and it's a lot. I hope y'all are ready for it. I think I am too. So we're going to both learn something tonight, maybe. I hope my era can get clicked and we can move. All right. So since we're into trauma, so we'll read this once and we'll probably hear it for the next 16 chapters. So trauma applies to the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for actual injured patients. I don't know if they're fakely injured. Is it different? Sorry, that was just my mind. That's how it is. My bad. All right, so the trauma overview, pathophysiology, assessment, and management of the trauma patient. You have your trauma score. You have your rapid transport and destination issues along with transport modes. Some agencies will call them different things. I don't know. We're going to learn what National Agency wants us to learn. So you'll have multi-system trauma. That's recognizing and management of multi-system traumas, patho assessment and management of multi-trauma and blast injuries. I wish I could show y'all some slides from that, but I can't. Uh, for people for people younger than 44, traumatic injuries are leading cause of death in the United States. Man, I'm kind of upset about just reading that because it's like I'm getting a little bit closer to knocking on that 44 door. I might have to start worrying about things. Proper pre-hospital evaluation and care can reduce suffering, long-term disabilities, and death from trauma. Trauma emergencies occur as a result of physical forces applied to the body. So there's so many different physical forces. Somebody tell me what pops in your brain when I say a physical force. Stabbing. All right. You kind of violent tonight, Mickey. I mean, what's up? You good? I mean, head to the windshield. Good one. Right. So anything like those gunshot, yes, those are all clear. Crow. We know not to mess with Travis either. I mean, yeah, well, we all kind of violent, but collisions, yes. Sorry. Nail guns. I've actually seen several nail gun injuries. I've I've seen tongues stapled to the wood, ears stapled to the wood, and they ended up just getting transported by the hospital. So yes, y'all are all right. We're all in the right path, and you will see we'll talk about majority of these besides the nail gun and maybe the crowbar to the head. Traumatic injuries may be caused by underlying medical conditions or medical illnesses may result from recent or remote traumas. That's a big part of it. Evaluation of the MOI of the patient of the trauma patient will provide you with an index of suspicion for different types of serious and or life-threatening underlying injuries. Ugh. Index of suspicion is your awareness and concerns for potential seriousness. That word's gonna kill me tonight. So y'all just know when I be like Siri, y'all gonna know that it's serious. Underlining an unseen injury. So that's the reason why when it's unseen, that's the reason why I've always told y'all so far, expose your patient and treat them. You can't treat a trauma patient for somebody. Whoops, forgot to do something there. So I'm a sticky note. So you can't treat it if you can't see it. So we need to expose it. We need to open it up. We need to move it out of the way so we can take care of them. All right. So energy and trauma. So we're gonna go kind of deep into this in a little bit. We'll talk about the three concepts of energies and stuff like that, so we can all kind of work down. Then we'll work our way up. Oh, there's a yawn. Traumatic injury. Occurs when the body's tissues are exposed and energy levels beyond their tolerance. Mechanisms of injuries is a traumatic injury is a way the traumatic injury occurs. Describe the forces or energy transmission acting on the body that causes the energy. So now let's talk about our three concepts. Three concepts of energy are typically associated with injuries. We have potential energy, kinetic energy, and energy of work. Energy can neither be created nor destroyed, but can only be converted or transformed. So, y'all Google real quick and y'all help out the other six in the class. Tell me one type of potential energy, kinetic energy, and energy of work. I want to see what y'all can come up real quick. Unless you already know it, that would be awesome. But let me know what y'all can come up with. Anybody? Anybody? All right, we'll move right along. Hopefully, y'all are looking. All right, so work is defined as force acting over a distance, forces that bend, pull, or compress tissue beyond an inherent limit results in this work. My wife's blowing me up now. That's what's taking my attention. She's like, look at this. And how am I supposed to look at that? All right. So potential is, Travis says, potential is possessed by a body, virtue of its position. Correct. You Googler. I'm proud for you. All right. Sorry. Next. All right, so here we go. It starts getting deep. This is the fun part. Kinetic energy is the energy of a moving object. Reflects the relationship between this mass, which is the weight. Um, Travis, I'll read that in a second. I see you down there. Is the weight of the object and the velocity, or the speed at which it travels. The speed. I'm sorry, my fat fingers typed in my notes there wrong. All right, Travis. Kinetic is energy which a body possesses by virtue of being in motion. Correct. That's and kinetics is like a car gun. Yes, exactly. Um, does anybody know the? Oh God, I forgot the. An object in motion, stay in motion. Who came up with that? Oh, I just went completely blank. Some theory. I forgot about that. I'm sure it'll pop up hopefully in a second. All right. So according Newton's law. Thank you. Ooh, yeah. Thank you, Mickey. I appreciate that. You saved me there. I'm hurting myself. All right, so according to the equation for kinetic energy, all right, so let's back this up. So Ke, which is kinetic energy, equals half the mass times the velocity squared. Well, I'm pretty sure we're not going to figure that up on scene. I can promise you. Well, what was the kinetic energy of that accident? He's in here with two broken legs, Doc. I don't know what you want me to do. That's more like my story if they ask me that crap. So according to the equation for kinetic energy, the energy that is available to cause injury doubles when an object's weight doubles, but quadruples when its speed is doubled. So don't get in a hurry, is what I got out of that. Potential energy is the product of mass or force of gravity and height, mostly associated with energy of falling objects. I watched this thing the other night about meteors and how they're finding people that's been hit with meteors that they go to the doctor and they or get an x-ray and they find this piece in their body and they don't know where it came from. I just don't know how you don't know you got hit by something that's now in your body that fell out the sky. I don't really know. That kind of confused me because I'm pretty sure. I mean, when a bird poops on you, you can feel that. I'm pretty sure it's a little bit more painful than that. So I don't know how people are going around finding that they have pieces of meteor in their body without remembering ever being hit. I'm full of useless knowledge. I'm sorry, y'all. All right, so the mechanism of injury profiles. Let's see. Different types of MOIs will produce many types of injuries, which we know that from what we've already seen. We've worked. Y'all see. Everybody's seen live rescue, live PD, all that. So y'all understand. And even the ones that hunt. Y'all know different calibers will be responsible for different injuries on an animal. Same thing. Non-significant MOIs, an injury associated to the body part or a fall without the loss of consciousness. It's not going to say that the fall is not going to be critical or hurtful. It's just they're just talking about it's a non-significant injury. Well, kind of in my brain, I'm sitting here thinking, how high was the fall? Were they standing on something? It could be. Significant MOIs, some significant injuries, or an injury to more than one body system. That's where you break out your multi-system trauma. Falls from height. Does anybody know the equation? How many? What is well, a fall from what height is 99% fatal? Does anybody know that one?
Say that again.
Oh yeah, somebody talks to me. A fall uh from what height is 99% fatal? Travis, 3 stories. You're close. So anything that's 1 times their height, they is. I've read it multiple times. Read it twice today. Now, doesn't seem like that's a big fall, because if you're 5 foot, so that's what 1 times, so that's five. So let's. Hey, you said it, Mickey. I didn't. So if you're, let's see. Hold on. Bring out the calculator here. 5 times 1.5. So a fall from 7.5 feet is 99 times 99% fatal. Yes. Yes. Yeah. That's what they say. I'm just going off what I read multiple times a day. I've questioned it. All right. So falls from heights, motor vehicle and motorcycle crashes. I've seen some motorcycle crashes and MVC versus motorcycle, to where the motorcycle walked away and the cars didn't. I'm not gonna say that I've seen that all the time. So, but it is possible. Gunshot wounds, stabbings. Y'all talked about that earlier, so we were already aware of that. Click. Um, Blunt and penetrating trauma. Traumatic injuries can be divided into 2 separate categories: blunt trauma and penetrating trauma. So, a blunt trauma is the result of force to the body that is caused without being penetrated to soft internal organs. All right, so that is like getting hit by the crowbar y'all mentioned about, or the baseball bat, or somebody taking a baseball to the stomach, to the head, to the face. Those are all blunt force. Still gonna hurt like hell, but it doesn't penetrate the body. Okay, we cool? Now I'm not gonna say that you ain't gonna break skin when you hit them. Y'all know what I'm talking about. All right, so penetrating trauma can cause injury by objects that primarily pierce and penetrate the surface of the body and cause damage to soft tissues and internal organs. So that's stabbing, that's gunshot wounds. Somebody come up with another one. What else do we have out there for a penetrating trauma? So we right now I have stabbings, we have shootings. What else do we? Let's see. Let's poke here. Um,
Glass.
what'd you say?
Glass.
Glass, correct. 2x4 to the head. Now, Travis, that could be a blunt force unless it broke the skin. Um, Now think about this. I think I may be using the wrong word, but when I'm talking about
Fork.
a fork, that's correct. That's stabbing. So if you have something under high pressure, like water at high pressure, like a pressure washer, when it's multiplied at a very high pressure, it will pierce straight through the skin. And that's what I mean by injection. I'm not talking about like with a needle or crap like that. So when I say injection, think about like high pressure, like uh, 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 hydraulic fluid. That's what I mean. You'll pick up what I'm putting down there? So either way, either type of may occur a variety of MOIs. It is important to consider unseen and as visible obvious injuries with either type. Depending on the mechanism of injury, if it's a car crash and you're like, damn, that looks bad, expect bad injuries. If they're not, that's great, but don't just be like, y'all look good, your car looks like shit, but y'all done. Insist on taking them to the hospital. Now, back to the nail guns. Right, Robert? Nail guns shot through the foot. Perfect. That will help you. Those are all penetrating wounds. Now that we are there, let's see. What's next? We're going to talk about blunt trauma. Um, Blunt trauma results from the object making contact with the body. Motor vehicle crash and falls are most common. Be alert for skin discoloration and pain. These may be the only signs of blunt trauma. Maintain a high index of suspicion. So, let's see, how do I put that? Coloration under the skin. Everybody knows that is more of like a bruising. Like if you get an IV and they blow your vein, you're gonna have bruising. Well, now think about that in a wreck and the seatbelt catches them, and it's not a seatbelt burn, but the seatbelt squeezes and holds them so tight, and when the body goes forward, it is a blunt force trauma. Because of the seatbelt obviously didn't move, didn't give no gate leeway, and they got locked in, and the seatbelt caused injuries. Y'all pick up what I'm putting down? Does that make sense? That the it's different types of, you may not see it initially, but check for the coloration of the skin. If things change color, there's high suspicion of an injury, that bruise that will bruise your face and chest. Yes, it can. It is. So think about that. All right, let me get back to my where this went. All right. So the next one. All right. So we're gonna have different types of motor vehicle crashes. MVCs, MVAs. It just depends on what state you're in, because some states list them as collisions, which is be an MVC. Some list them as MVAs, motor vehicle accident. Depends on your state. Doesn't matter. All right. So we have front end, rear end, lateral, rollovers, or rotational. I know them more as a head-on T-bone, or they got hit and they spun down the road. Yeah, I mean that's just me. I mean I'm from Mississippi kid now. Excuse me there. The bottom was really not important. So let's talk about this one. Uh, a crash consists of three collisions: a car against another one, tree, or an object. Damage to the car does not directly affect patient care, but does provide information about the severity of the collision. While assessing the vehicle that has crashed, you can determine the MOI. All right, I want to on my I'm trying to look for something else real quick while we're pulling up a case study. So y'all get ready. I know we talked about this earlier. Let me get rid of that. Make that bigger. Get that right there. All right. So y'all get ready for this one. Hopefully y'all will talk about this like we did the other day. You and your EMT partner are dispatched to the scene of a reported rollover type motor vehicle collision. As you approach the scene, you see skid marks on the roadway continuing off into the dirt. After ensuring the safety of the scene, you approach your patient. You find a 33-year-old man lying supine in the dirt. Bystanders state that they assisted the patient from the vehicle after witnessing the vehicle roll over multiple times. Approximately 30 feet from the patient, you see what appears to be the vehicle on its top in the ravine. Y'all think about that one for a minute. All right. So look at here. So passenger against the interior of the car. Oh, sorry, I lost my notes. I can't talk about it on my notes. Passenger kinetic energy produced by the passenger's mass and velocity is converted into the work of the stopping vehicle of his own body. All right, so here, patient sitting right here. If the car is going 85 miles an hour down the road, how fast is the patient's body traveling? Does anybody want to guess? All right. So no matter what, the body is going with the vehicle. Now, in this picture, we're doing 85. The entire people in the car is doing 85 miles an hour. It suddenly stops. The car is going to stop on a dime, but where is the body going? The body
Forward.
the body's still going forward. It's Hold on, before I quote myself wrong. Newton's law again, an object in motion may remain in motion until the motion is stopped. Well, guess what? This dash is going to stop it. So they didn't do anything. Oh, where'd my marker go? So the body can't stop like the car is because it's made out of metal and it's going to crinkle, but the body has to stop somewhere. Well, the bones are going to give when you come down here, so you're going to have knee injuries, you'll have
Mhm.
wrist, arms, elbows, and facial, chest, pelvic. Bro, y'all going to have so many multi-system trauma, you're going to be like, I need another truck. I'm going to let
I
this
need a
play.
bird.
Well, so we're going to talk about that. Benefits of ground transport versus air transport. We're going to go over that in a little bit. I think it's also a discussion, if I'm not mistaken, that I saw today that we have discussions out there. I didn't know that. So some of the
But
common injuries we're going to see, well, we just talked about lower extremities. You're going to have a flailed chest, head trauma. That's just to start. Those are the big issues, and that's just to start with. That is not even a guarantee of what else you're going to have. Because think about, oh, I don't know who you're talking about, but so the body will go 80 miles an hour. Well, the car that they're traveling is 85 miles an hour.
now it's gonna go 170. And don't you supposed to double it?
It is going to double.
Oh, well, with impact. If the vehicle's going 85, don't you supposed to double it? The speed, and that's
Right.
considered a impact.
Now y'all picking up what I'm putting down. Now, will, will if they don't have the seatbelt on, will the dash stop them? Well, yeah, eventually they gonna stop, and this thing, they head's gonna hit right here too. Cause now I'm gonna pick on every one of us, the 6 or 7 of us in this class. Your big old head gonna keep going forward. What's gonna stop it?
The
I don't even know
crash.
what none of y'all look like, and I'm picking on y'all. Just wondering if it'll throw them out. Yes, Travis, it can. It can put them out the window. They can go from it's like an under and over because most crashes they go over and under. They come up high, hit the windshield, and the seatbelt pulls them back down, and then they have double injuries. That's where you'll have pelvic injuries, you'll have chest injuries from here, from the airbag. Then you're gonna have respiratory from the seatbelt airbag dust. You'll have seatbelt injuries. I can't tell here, but it doesn't appear that this seatbelt was on because if y'all have ever been in a bad enough wreck, these seatbelts, and that looks like a blazer if I'm not mistaken, but these seatbelts will lock out in the out position, and you have to cut it. If y'all kind of look right there, it don't even look like the seatbelt was in the the clip. So they cut this seatbelt and it wound all the way back up in here when they cut the B post. So this person potentially didn't even have a seatbelt on, and now you're like, oh god, this is bad. You know, I'm not sure if they cut that and or they cut right here. It doesn't look like they rolled the dash any, but they made obviously they made the B post go away so they could cut them out. So, I mean, obviously it's bad. I mean, you don't see no blood or anything on the seat, so that's beneficial. Maybe it's just all internal trauma that we can just be like, oh, Jesus, let's go. Let's hurry up and get there. Now, look at here. So, passengers' internal organs against the solid structures of the body. Internal organs may not be obvious as internal injuries. Hold on. I read that completely wrong. Internal injuries may not be as obvious as external injuries, but they often are forgotten most life-threatening injuries. All right, so we're here. I'm going back to my case study where we talked about the MVC. Whoop, wrong mouse. All right. So we went to found a 33-year-old male laying supine. All right, remember that one? How does the basic understanding of kinetic energy contribute to the care of the trauma patient? Does anybody guess? Want to guess? That's kind of deep though. Let's see. Understanding the concept of kinetic energy helps to provide clues concerning how much energy was transmitted to the trauma patient based on the mass of impacting object and its speed, and how were injuries to the body may be based on the transmitting energy. That's deep for a Mississippi kid. I'm just gonna let y'all know. All right, we're gonna roll on. So vehicular crashes. You can have death of an occupant in a vehicle, severe deformity of the vehicle, or intrusion. So when we mean intrusion of the vehicle, means something came into the car. Let's say like if they hit the tree made intrusion to the vehicle. It deformed the tree. Tree may have wrapped around it, or something made it got into the structure of the vehicle. Moderate intrusion from a lateral accident where the car is now smaller than it should be because of the way they got hit. Severe damage to the rear, maybe from a rear end damage. Crashes in which rotation is involved, that's getting hit from the side and spinning down the road. Or, like Travis pointed out, they can be ejected from the vehicle. There's multiple ways. I've seen people with seatbelts get ejected, people without seatbelts get ejected. People with seatbelts die, people without seatbelts die. It's a complete personal choice, unless it's a state law. Uh, it is what it is, boys. All right. So we're going to evaluate supplemental restraint systems, maybe a KED, the backboard, C-spine precautions on every single one of them. Determine whether the passenger was restrained by a full and properly applied three-point restraint system. Ugh, maybe just say they got the seatbelt on, man. You make it all difficult with three-point restraint. Whew. Determine whether the airbag was deployed. That's going to be obvious. You're going to see that to get go. But y'all know, y'all seen some airbags have to get hit in the right place for them to deploy. So they may not get deployed. It may just be um, not even a hard enough collision for it to deploy the airbags. Um, Seatbelts may decrease the severity of the collision. Could be. Um, Airbags decrease the severity of this deceleration injuries and decrease injury to the chest, face, and head. You know, I'm not going to tell you that it's not, because that's what they're designed for. But that airbag may cause just as much, if not worse, injuries due to the force that it's causing when it blows out. Because that sun gun got some force behind it. I don't know if y'all have been in a wreck, but them sun guns move. So despite airbags, suspect injuries. So you're looking at extremity injuries or internal organs. Now, I will say, just because it's an airbag, look for injuries caused by the airbag. Look on the inside of the wrist. Um, Ladies, majority of the time, drive with two hands on the wheel. Look for injuries on the wrist. Men, majority drive one-handed, so look for injuries on the wrist there. And look for broken wrist. That'll also tell you a sign of it or not. Or you may just not be able to.
Hey, Chris,
Yo, come on.
how fast do those airbags come out? I think I was told they come out at 200 miles.
Let
Is that true?
let's Google that.
Can you hear me?
Yeah, I got you. Can you hear me?
Yeah.
Uh, I can't answer that, but you know what I'm gonna do? I'm gonna Google it. All right. It says typically a front airbag will deploy for unbelted occupants when the crash is equivalent to an impact into a rigid wall at 10 to 12 miles an hour. So you got to hit something going 10 to 12 miles an hour for it to come off. All right. For an unseatbelted person. Those airbags will deploy at a higher threshold, about 16 miles an hour. All right, so I guess that's the national standard. Now let's see how fast. What's say here? I don't want that. Um, I don't know. Um, now Maximum to inflate an airbag, it says it takes a lot less than 5 psi, but that's a lot. I'm gonna let you know it is a lot. 5 psi. In most cases, hang on for this one, Woo. The airbag will come out at a speed between 100 to 220 miles an hour.
I thought so.
Yeah, so hang on to your
I
britches,
was just trying to make sure.
sir.
I was just trying to make sure I was told right.
Yep. All right. So children shorter than 4 foot non should ride in the rear seat. Obviously, there's a reason why. Seatbelt can break their neck too. In a pickup truck or a single-seated vehicle. I know what single-seated vehicle is besides a motorcycle. I mean, are they talking about? I don't really know. The airbag should be turned off.
Also, class, make sure y'all keep that in mind now. Airbags come out, they come out between 100 and 200.
Yep.
Keep that in mind now, class.
Y'all might see
So
that.
if y'all get somebody hit with the airbag, y'all keep that in mind. That's a lot of speed right there. Lord have
Right.
mercy.
I can break a lot. Remember that if the airbag did not inflate during the accident, it may deploy during extrication. Now, I do know this. That's why a lot of fire departments go and disconnect the battery. Airbag can deploy still up to 30 minutes after the incident. So a lot of departments have these airbag deflators. They'll go and sit. They strap them on the seat belts, or they have this thing that connects to the dash for the passenger side, to where if the bag goes off, it doesn't bust out into the passenger compartment and potentially hurt you or the patient worse. So it depends on your department. They may have that. Now, here's a good picture. Remember
Cool.
that
No,
supplemental restraint systems can cause harm, whether they are used properly or improperly. Hip dislocations may result from seat belts if they're worn too low. Internal injuries can occur when the seat belt is worn too high. Lumbar spine fractures are also possible, particularly in children and older patients. Now, this right here is a bad ass seatbelt injury, but that's okay. He'll be fine. I'm just worried about the hand marks, where it looks like somebody slapped the hell out of his stomach. Y'all kind of see that with the jacked up hand? Look, like there's a thumb, there's a jacked up finger. You know what I mean? No, I'm speaking. I don't know. I have no idea what that is. It could be just blood wiped off. But you can see here, this is not what's going to hurt him. The internal issues here down in the stomach may hurt. He's going to have potentially could have some cardiac issues. Obviously, there's a lot more worse wrong with him because he has two large bore IVs in both arms. So he's potentially a trauma patient. Um, it's an old ass seat collar, I can tell you that. But I mean, there's probably a lot more worse wrong with him than what we're really seeing. So a passenger riding in a vehicle is equipped with side airbags, but not wearing the seat belts are often thrown forward and come into contact with the airbag and or the doors at the time of deployment. So I'm just going to tell you, wear your seatbelt. It's the best thing you can do. Helps potentially keep you inside the vehicle. So look for contact points between the patient and the vehicle uh, as you perform simple, quick evaluations of the interior of the vehicle. You know, and if you don't know if a car has it, when I say a post, do y'all know what I'm talking about? I just want to make sure before I try to keep going and saying the ABC post, if that makes sense to y'all. I'll just give y'all a little hint if not. The A post is the post that comes down on both sides of the windows. The B post is between the front seat and the back seat. And C post is the big post from the roof that comes down between the roof and the trunk. That's A, B, and C. Most vehicles or common vehicles have A, B, and C until you start getting to your Suburbans and Tahoes and stuff like that. And same thing with school buses. They just A, B, C, D, E, F, whichever way you need to keep going. All right, so rear end crashes. Rear end impacts are cause whiplash, particularly in the absence of an appropriate placed headrest. Sometimes people will take those headrests out, and they'll cause a whiplash issue there. Um, As the body is propelled forward, the head and neck are left behind. The cervical spine and surrounding area may be injured. Acceleration to the injury to the brain is possible. And third, conclusion of the brain with the skull. So collisions. So you're basically looking at the head gets whipped back, slams forward, and comes back again. That's also called the coup contra two effect because the skull hits the back of the head, hits the front of the head, the brain. The brain hits the back of the skull, then the front of the skull, and then the back of the skull again. So it's coup contra coup, and they also may be having a concussion or a TBI from that. Depends on exactly how hard that was. Something else you need to think about. Look for the bruising around the eyes because that's called battle signs. It's brain injuries. Some side impacts. I'm assuming this is going to be lateral, even though it looks like they possibly rolled. It's just my opinion here. Lateral or side impacts are very common. Causes of death associated with motor vehicle crashes because car could strike them right here. Or that kind of looks like an old F-150, single cab F-150. So there's not much room for the driver or the passenger to have room to go anywhere if they're hit. You can have intrusion of the vehicle right here to where the car hit them so hard. It intruded inside the compartment of the vehicle. So think about that. Let me get a drink here. All right. A vehicle struck from the side is usually struck above its center of gravity. Begins to rock from side to side. This results in the passenger sustaining lateral side to side whiplash. We all know what whiplash is. At some point, you've probably had it, didn't realize what it was. If you were involved in a small little wreck, it could have been whiplash, and you're like, man, why am I so sore? Well, it's the same thing. It can cause that. Let's see. If there is substantial intrusion to the passenger compartment, you can think about a lateral chest or abdominal injuries on the side of impact, possible fractures to the lower extremities, pelvic, and ribs, organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in a motor vehicle crash as a result of lateral injuries. See, I didn't know that, so I had to put that in there. Oh, you can't see I'm moving the wrong mouse. So I'm going to say that again. Organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in a motor vehicle crash are a result of lateral collision. I didn't look at y'all's test for tonight, so I just didn't tell you. I don't have a clue. All right. Large trucks and sport utility vehicles are prone to roll over because they sit higher. Their center of gravity is a little bit higher. You get something that's top heavy already, it's going to be easier to roll over. Injuries depend on whether the passengers were restrained. The most unpredictable type of injuries that are caused by a rollover crash in which the passenger is unrestrained, because you have no idea what's supposed to happen, where the body's going to go. Are they going to stay seated? Are they going to get thrown around inside the vehicle? Or are they going to come out? The most common life-threatening event in a rollover is an ejection or partial ejection from the passenger of the vehicle. So they're either going to be fully thrown out of the vehicle, or you may have an arm, a leg, or something like that get thrown out of the vehicle. 2 seconds, y'all. So think about that. Even when restrained, the passengers can have severe injury, which we know that depends on the high speed of the incident. So rotational crashes are where they spin. You can get hit like from a lateral hit, but could be on the front or the rear, and the vehicle spins in the direction that they were hit. So if they were hit on the driver's side rear, they're gonna spin driver left. Does that make sense to y'all? I don't know. I see it in my head, but I don't know how well I explain that. The rotation of the vehicle as it spins provides opportunities for the vehicle to strike objects such as utility poles. Well, yeah, because they can't stop, so and you can't spin around them, so you're gonna hit whatever you hit. Injuries are often graphic and apparent. There can also be serious unseen injuries into the body system. You must maintain a high index of suspicion for unseen injuries. Always, always, always expect more than what you see. Just because you just see their their index finger broken and a right crown tooth missing, that maybe the tooth has always been missing. Always think there's more injuries than what you see. It is always nice to ask, sir, about how fast were you going? Ma'am, can you tell me what you think you were doing at the time of the incident? How fast do you think you were driving? Whether the patient was thrown through the air and at what distance, where were they struck and where did they land? That's important to you because you can write in your report. Patient's vehicle flew approximately 15 feet in the air. Surface of the patient landed on. Did they get thrown from the car and on a highway and land on the concrete embankment, or did they get thrown from the car and land in the grass and it was the wet ground? All right. Sorry, my son can't read a calendar. Evaluate the vehicle that struck the patient for structural damage. I don't really care about that because if you just say, you know, describe it, take pictures of the wreck, take it to the hospital with you. Just don't take pictures of people that were in the wreck. If you're a full basic vehicle or even with an advanced, ALS backup should be summoned for any patient who has have or thought to have sustained significant MOIs. It's just because you can have airways and you can sedate them. That's the reason why they're pushing for medics. So, car versus bicycles. Now remember, if you're the first one there and you know it's going to be a multi-patient incident, you're the last one to leave. Some agencies may tell you that you grab the worst and you leave. Well, if the worst has to be extricated, you can't really leave. All right. So there's probably gonna be a lot of damage to the bike, even though like evaluate the bike. It's crushed. You know, take pictures. We all have smart devices all of us all the time, so think about that. If the patient was wearing a helmet, I highly suggest to bring the helmet with you. Um, Somebody within that hospital is going to want to take a look at it. Probably going to be your trauma surgeon. Maybe they'll use it as a teaching tool there. It's somebody's going to mess with it. I can promise you that. And even if you send them pictures, they're going to be like, well, is there any way somebody can bring it here? Well, I don't know. I mean, so save yourself some trouble and try to see if you can bring that helmet with you. What time is it? All right. Presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise. Always, always, always protect the spine. In any vehicle crash, if they're up, moving, walking around, and you see them shaking their head, that's okay. But if you walk up to them and there's a person sitting in the car, just reach over and be like, hey, listen, I'm going to have my partner. They're going to come sit behind you, possibly if you can get them back there. And they're going to hold your head until we can keep you from moving your head from side to side. I'm going to ask you a bunch of questions. Don't nod your head up, down, or side to side. Answer yes or no or for the best of your ability. As you can tell, I've said that multiple times. That's just me. Um, protection from, let's see, car versus motorcycle. Protection is from helmet. Does not always protect severe cervical spine because I don't know how many bicycling helmets do that. Couldn't really tell you. Motorcycles can also leather or abrasion resistant clothing. They can help. A lot of people, let's see, cruisers majority will wear leather. Some of your sports bikes will wear the lightweight jackets. Got pads built into them. The shoes that have the carbon fiber tips, all kind of such stuff. We talked about boots there. Collision will occur against larger vehicles or stationary objects because people don't pay attention to motorcycles. They drive carelessly because there's potentially motorcycles on the road. Sometimes the motorcycles drive carelessly. Speed. I'm not saying every motorcycle speeds, but it's easier for them to get up to speed and go and move around away from them. That's why. Um, let's see. When assessing the scene of a motorcycle crash, look for deformity to the motorcycle. That's most likely going to be. I don't know if I've ever worked a motorcycle wreck and the bike has not had 80% damage. I don't know. Um, you look for obviously the sides because they're going to lay the bike down and skid across the road. So they want you. I don't really know why they're telling you here to determine the skid in the road or determine the stationary object or other vehicles. Could be a hit and run. Maybe they hit a curb and that's what flipped the bike on its side. And then, so the location of the deformity in the helmet, let's see, like if it's to the right temple, was this area covered underneath the helmet? Was the helmet still intact when you got there, or was the helmet knocked loose? Those are very important things to document um, because you need that information to build a rapport with the hospital and it helps you write your report better. There are four types of motorcycle impacts. You'll have your head-on crash. You'll have, which we know what that is. I'm not gonna worry about it. Reading that one. Angular crash. The motorcycle strikes an object and or another vehicle at the angle so that the rider sustains direct crushing injuries to the lower extremity between the object and the motorcycle. I mean, that's a lot of them are going to be side to side, or they're going to be front end or rear end. You'll have an ejection. I'm pretty sure every wreck's going to have injection there. I mean, ejection. Control crash, a technique used to separate the rider from the. So what this is telling you is like if the bike goes down and they're an experienced rider, they're going to try to kick away from the vehicle, from the motorcycle, which means they're going to separate themselves from the weight of it and that they can move freely. If the bike tries to weigh them down and bring them down, it's going to cause more injuries. We're gonna hit these next three slides, and they're just on fall, so we'll hit those and we'll take a break. C. The injury potential of a fall is related to the height from which the patient falls. More than 20 feet is considered significant. Internal injuries pose the greatest threat to life. You will, a lot of times, will see broken ankles. Sometimes the bones will get compacted all the way up into the pelvic area and may blow out a pelvic joint. You can see some back injuries from these where they can have compression injuries. Uh, I've seen some people blow their heels out from this. I actually have a really cool picture, but I couldn't get it transferred in time from a guy jumping and blowing his feet out. Really cool. I don't really ever know how he did it, but I got to run that one. I wasn't sure. Here's just some pictures of some of the other injuries. Like we were talking here, blow it out here. These legs, this right here, a break. I've seen this get forced up in here, blow your hip joint out, and also cause lower back injuries. I think ultimately that's really kind of what they're showing you. It's because they're saying here is the legs may absorb the energy in the fall, or they just may not, and it's just gonna go poop and be done with that. I'm sure y'all like that one. Poop. All right. Taking into account the height of the fall, the type of the surface struck, the part of the body that hits first, followed by the path of energy. So, and that's another reason why when you're in the military and they're teaching you how to parachute, no matter what class you go to, what different group, they have a basic. They teach you how to fall when you're landing. You don't just see like you see all these skydivers across the world, they just hit the ground running. Well, that's not always true. They may, what they're taught is bend their legs, put their feet together, when they come in contact with the ground, they drop like they're trying to like buckle from like it's like they're standing 6 feet tall and their knees and feet their feet come in contact and they just bounce their feet and fall as one unit. So the energy is displaced throughout the body and not just the feet. Um, there's different ways to fall and absorb energy or displace energy. So the military teaches it. I'm not going to say they teach you the best because a lot of time we have these, parajumpers, parachuters, skydivers. They always have back and knee pains. Guys, I see it's close enough to 7. I'm gonna give y'all a 10-minute break. I will see y'all back at 7:0. Just make it 10 after 7. How about that? I'll see y'all at 7:10. Be right back. All right, welcome back. Welcome back. Now y'all are so excited, but we got a lot more to go. All right, so going over penetrating objects. So penetrating trauma is the second leading cause of trauma death in the United States. After blunt trauma, low energy penetrating trauma may be caused by accidentally by impalement. I don't know, you accidentally impale yourself with a knife. Maybe you can. I mean, I don't know. Intentionally by a knife, somebody don't piss off somebody. Ice pick, or other weapon. Many times it is difficult to determine entrance and exit wounds from projectiles in a pre-hospital setting. If it's by like a knife jab that's not left there and it does have an exit wound, bullet wounds for sure. You don't know which one's entrance and which one's exit. So you combine the information with the important things you already know about the patient, the potential pathway. So like if they say the patient was running away and fell, and you heard gunshots as they were running away. Well, do you think maybe they were shot in the back? It's hard to know. You just try to say, hey, I think that they were shot from the back. I don't really know, but we're gonna give the best judgment. With low energy penetrations, with low energy penetrations, energies, injuries are caused by the sharp edges of the object moving through the body and are therefore close to the object's path. Knives may also be deliberately moved around internally, causing more damage than external wounds suggest. Try to determine the length of the penetrating object. If you happen to see multiple knives at the scene, look for the one that's got blood on it. That'll tell you which one it is. Nope, maybe they got stabbed by multiples. In medium and high velocity penetrating trauma, the path of the projectile, well, can be usually a bullet, may not be easily to predict. The bullet may flatten out, tumble, which means flip end over end, or even rocket within the body before exiting. 22 caliber are the most ones that do that. The path of the projectile takes the trajectory. Fragmentation depends if the bullet breaks up. The bullet's speed is another factor in resulting in the injury. How far away were they? Was it a point blank? Do they have blast injuries from where they shot when the gun was pushed against them? That's some of the other telltale things that will kind of help you out. So if anybody understands this one right here on cavitation, it's a lot. It makes you understand. So the bullet enters here. As it enters in, creates a pocket. Everything is pushed out, and let's say that's up and down, obviously by the picture. The bullet may tumble through here, and then it flattens back out and continues on. But if it's a straight path through here, like the bullet is right there, the cavity is created, and then the bullet. You notice how the path is real small here, gets real big, and then it stays the size of the bullet on the way through the body. Um, it can cause serious injury to the internal organs distant to the actual path of the bullet. So due to the internal pressures, due to the trajectory of the bullet, you may have a lot more internal organ issues. Permanent cavitation injury results closer to the bullet path and remains after the projectile has passed through. So it's like getting shot with a bow and arrow. You're going to have a hole in you, period. It's not just going to close because the object is out. The relationship between the distance and severity of an injury varies depending on the type of weapon involved. versus a 9mm bullet, which is semi-small. It travels super speed versus a 45 caliber bullet, which is a very large one. That is, it travels fast. Don't get me wrong, but ultimately it's a slow bullet. So it all depends there. Air resistance often refers to as the drag, slows a projectile, decreasing the depth of the penetration and energy of a projectile, and thus reducing damage to the tissues. That's a lot. So what it's saying is, the bigger the bullet, the smaller the more the drag is created, and sometimes those big bullets, yes, they're going to be under high velocity and high speed, but the bigger the bullet, the smaller the impact can be of the trajectory, but you're going to have a lot of fragmentation and a big old hole, a big old exit wound. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile. Whew. This is one reason that exit wounds are often many times larger than the entrance wounds. You may have pinhole entrance, and when they exit, you may have big enough for 2 fingers to fit in. Any information regarding the type of weapon that is used should be relayed to the hospital. It's important. You need to know, hey, this guy was shot with 445 round bullets, or 445 caliber bullets. That tells them a lot. It helps them plan a lot of things. So here's a chart that breaks it down in your book. If y'all are following along, please do take a look at this for just a second and see if it makes sense to you guys. All right. So going on to the next of blast injuries. So we have my also seen mines, shipyards, chemical plants, terrorist attacks. Yes, a lot. So here, let's talk about blast injuries. So here's your primary blast. Your secondary blast that comes out. You have your tertiary. Not many times you hear your quaternary. I guess it's quaternary. Quaternary. I can't pronounce that. Obviously. Um, So here you're gonna have uh, projectiles flying out is gonna be the bigger part here. Um, Sometimes bombs are created with like ball bearings, nuts, nails, different size nuts screw on different size pipe. You can have all sorts of things in there. So tertiary injuries is when you get blown against something. Like if I'm standing and I get blown against the wall because it's big and it's not going nowhere, and you're going to see a bigger injury. So that's your tertiary. Um, then the last one, quaternary, is collateral injuries such as burns, crushing injuries, and toxic insulation. So that's what's going to come from the heat, the potential chemicals that are inside the bomb that are now aerolized. I mean, there's so much that we could go into that, but I'm gonna keep it simple. All right. So people who are injured in explosions may be injured by 4 different mechanisms. All right, let's go over those real quick. So you got your primary blast is these are due to the entirety its blast itself. Damage to the body caused by the pressure wave generated by the explosion. Secondary blast is damage to the body results from being struck by flying debris. Tertiary blast, the victim is hurled by the force of the explosion against a stationary object. And here comes the last one that I don't have trouble with. Uh, Miscellaneous blast injuries, burns from hot gases or fire started from the blast, respiratory injury and toxic inhalations, crush injuries from the collapse of a building, suffocation, poisoning of other medical injury emergencies, contamination of wounds from environmental chemicals or toxic substance. Most patients who survive an explosion will have a combination of the 4 types of injuries. Um, uh, you may not always see the tertiary where they're thrown against something or building collapse, like specifically the IEDs. Yeah, they'll come in contact with the ground, but not necessarily something that is going to throw them up against something or an object being thrown on them. So not all of them's going to have all of them, but majority will. Tissues at risk. So anytime there's a pressure change, something's got to give. Organs that contain air, such as the middle ear, the lung, gastrointestinal tract, are the most susceptible to pressure change. That's why I can't hear Jack out of my left ear. Junctions between the tissues of different densities and exposed areas, such as the head, neck, tissues are prone to injury as well. The ear is most sensitive to the blast. The tympanic membrane involved to detect minor changes in pressure will rupture at about 5 to 7 pounds per square inch of atmospheric pressure change. So it doesn't take a whole lot to change the pressure, and your eardrums are blown. I had my eardrum blown out once as a little kid, and then I had it blown out in the Middle East. I have scarring in my left ear. Uh, I'm notoriously, if you talk to me, I have to turn my head and be like, huh? I hate saying that because I always feel like my dad, huh? Can't hear you, son. Talk louder. But now I know why he's always said that because he can't hear. So your pulmonary blast injuries are defined as pulmonary trauma that results from short-range exposure to the detonation of explosions. Primary blast injury is often characterized by the lack of external visible injuries. So just because you can't see it doesn't mean it's there. They may not be able to hear you because of their eardrums are blown. They may not be able to tell you that their stomach their stomach may be ruptured or they may be bleeding out on the inside because they can't feel it. Pulmonary edema may ensure rapidly, so the fluid's got to go somewhere. One of the most concerning pulmonary blast injuries is arterial air embolism. They're gonna have to start having trouble breathing. It's because like I feel like I can't get a deep breath. You can decompress. Well, you can't, but medics can decompress them. Which occurs on the alveolar disruption of the subsequent air embolism into the primary vascular space. So, like if you palpate the chest and you're feeling for Rice Krispies when you uh, palpate the chest and you're checking for injuries, you'll feel something that is like it pops when you touch it. It's like I can't describe the sound of it. It's if you're used to palpating a normal chest and you palpate it and you don't hear air movement on one side, most likely you're going to have a PE over there. Not a PE, but like a pneumothorax. Sorry. This can cause disturbance in visions, change in behavior, change in states of consciousness, and a variety of other neurologic issues because of the blast. So not just can it cause internal ear trouble, but can create different types of mood patterns. Solid organs are relatively protected from shock. That's because they're called solid organs. Hollow organs will have more issues. May be injured by secondary missiles, or so they're talking about impalements. Neurologic injuries and head trauma are the most common cause of death from the blast injuries. Subarachnoid and subdural hematomas. You're going to see those pretty much. That's a lot of your military guys would have those that have traumatic brain injuries. Bradycardia and hypertensive are most common, so you're going to have a low heart rate and a low blood pressure. Extremity injuries, including traumatic amputations, are common. I'm going to say are always common. Even depends on how close you are, but I've seen a lot in my time, and I don't care to see another blast injury. So multi-system trauma involves more than one body system. We know that. So that's why it's called multi-system. If you have, you know, head, neck, and face. That's neuro, respiratory, and they could have breathing trouble. They could have issues to where they're auditory, they can't hear well, and their mood changes. So you're going to have multiple things fighting against you to get it to treat your patient right and to move forth. Um, let's see here. So your main priority on the scene of you're going to talk about. Not real sure if they're talking about the explosion or just in general. So, but obviously our main safety is the safety of your crew, your patient, yourself. How many more people do we need? How many people do I see out there and I'm like, oh God, why am I working today? It's I've said it multiple times. Know your abilities and know when you say we need all the help we can get. And most of the time, if you respond to what we've talked about already, your dispatch, whatever, is going to automatically dispatch several units to you. Identify and manage life-threatening injuries. We've talked about that maybe 100 times in the past chapters. If you see it, fix it. Now, I mean, if it's an impalement, you may just have to stabilize in place unless it's messing with the airway. If it's in the face or in the face cheek, that's the only time you remove it. Everything else you leave in place. Now, I'm not talking about like if there's an impalement in the brain and to the forehead, don't pull it out. No, if it's impalement in the cheek that's causing respiratory issues, remove that. Control the bleeding. Now, if it's fitting, use a tourniquet. Protect the spine with spinal mobilization. We know that anytime that you think that somebody's going to have some issues, put it on them. Put the seat collar and backboard on them. If you run out because you've used them on almost every patient, we got other units coming. Don't worry about that. And always send them to the right hospital. Don't just send them to be like, oh, okay, well, they're taking patients over there. That's an MEA. Yeah, they're going to take some patients and it's going to be walking wounded, not a serious patient. So y'all remember that, okay? Get the right patient to the right facility for the right treatment. Definitive care requires surgical. If all your depends on what system they're going to teach you. I don't want to say different colors based on your triage, but depends on what the severity of the injury is what patient needs to go to what hospital. That's what we want to say. If they're critical, send them to the trauma center. If it is a non-critical injury, send them elsewhere. Or you may have a dispatch center or a control center that automatically tells you under a MCI of where these particular patients need to go. Um, so we'll talk about patient assessment for a little bit, and then I know we'll pick up a different one. Um, Patient assessment consists of, I hope y'all know this, because we've only talked about it a lot. Um, Let's see. So patient assessment consists of scene size up, primary assessment, history taking, secondary assessment, and reassessment. When you're caring for a patient who has experienced a significant MOI and the patient is considered to be in serious or critical condition, you should perform a rapid physical exam. You don't want to take your time and beat around the horse and talk to old John that's over there. Hey, buddy, how you doing? No, it's rapid. You have to go head to toe, expose the body, take care of your business, and get moving on with this patient. Do they need to stay in? Can you stay and play with them, or can you load and go because they're critical? With a patient who has experienced a non-significant MOI, focus on the chief complaint. Like we said, don't treat what you see. Treat what the patient thinks what they say is wrong. Even if their right arm is hanging off and they're like, man, I can't hear jack out my ear. Okay, well, cover their ear up. Try to treat that. Injuries to the head, you're gonna have. It is a disability because it's an unseen injury to the brain that you can't fix that. If you can fix it and you're a neurologist, I'm not real sure why you're in EMT school. I'm glad to have you here, but if you know it, please speak up and help me out here. Bleeding or swelling inside the skull is very life threatening. I don't know why they put often. It's very because there's only so much space that it can swell. It just can't. It's got skull around it. It can't swell everywhere. So you want to include frequent neurologic examinations of your assessment. Some patients will not show obvious signs and symptoms of a head injury. You have to do a good assessment to pick that up. And that's what you need to get done. A rapid assessment and then a focused assessment on life-threatening issues during your assessment. If you find something that's a life-threatening issue during your assessment, stop, fix it, and come back to what you're doing and do it. Same thing when you're doing your checkoff skills. If you're assessing them and and you come across and you need to apply a tourniquet and direct pressure and elevation, you fix it right then and there. Don't say, "Oh, I'm gonna come back to that," because you will fail majorly. Majorly, fix it right then and there. All right. So injuries to the neck and the throat. This is an area of serious or deadly injuries. The trachea may be torn or swollen. That's bad. Just gonna let you know. Airway problems may result that could quickly become a serious life-threatening issue. Your assessment must include frequent exams looking for decap BTLS to the neck region. Everybody knows what decap BTLS is that right? Come on, show me 8 answers, please, if possible. I'm not asking y'all to, define it all out, but please let me know if y'all know what decap BTLS is. Bueller. All right, I'm gonna keep going. Hope y'all answer me as I keep going. Also, assessed for the jugular vein distension, so JVD is also considered jugular vein distension, and trachea deviation. You will look for the cricard, the veins in the neck to be extended due to the pressure, and the trachea. If you look straight ahead, look up just about a 45-degree, feel exactly where your trachea is. If it is deviated from side to side at all, that's tracheal deviation. That's very serious. Swelling may prevent blood flow to the brain and cause injury to the cervical CNS. Guess what? If they have JVD, guess what they're gonna have? They're gonna have some swelling, and they're gonna start having brain issues. Mallory Wright. Deformities, contusions, abrasions, punctures, burns, tenderness, laceration, swelling. Thank you. To last. All right. Penetration injuries may result into an air embolism. The only way to get rid of that is do a chest decompression. I'm sorry, you can't do yet. Hopefully, you can do it when y'all all come back to EMTA school. A crushing injury to the upper part of the neck may use the cartilages may cause damage to the cartilage of the upper airway and larynx, and it may cause fractures to them. And once those are fractured, that's a surgical way to fix that. I'm not real sure what that surgery's called, but I know you got to have. Oh, I know somebody who's had it and had a four-wheeler motorcycle wreck, like an ATV motorcycle. It's an off-road bike. Oh well, I'll think of it later, and probably when I'm laying in bed, and everybody's gonna be like, "Why'd you think about it then?" It's crazy. All right, so chest injuries. The chest contains. I hope y'all know what's inside the chest. I hope that we shouldn't have to tell you that. Many life-threatening injuries may occur. You have broken ribs. That's what's potentially going to keep them from breathing good. It's going to be like, oh, my right side, it hurts to breathe. Oh, God. It may puncture the air. It may puncture the lungs. So now they're even more shortness of breath. Bruising may occur to the heart and cause irregular heartbeats. You pick that up if you have the ability and you put them on the monitor. If you can, if you have an EMTA or a paramedic. If not, you're going to be checking for a pulse. Large vessels of the heart may be torn inside the chest, causing massive bleeding and potentially fast death. Air may collect between the lungs and the soft tissue in the chest wall, known as a pneumothorax, and you got to poke it to get rid of it. First time I heard that when I decompressed somebody, I was like, oh, what was that? And nobody else was around. It was just me in the back, and I was kind of like, oh, okay, I want to do it again. It didn't work. Penetration or perforation of the integrity of the chest wall is also called an open chest wound. Uh, if left untreated, they are going to go into shock and they will die if you don't treat that. This is a critical incident if there's any kind of integrity problems, maybe from a flailed chest where they have a broken rib and two sides and it's not in place and it moves up and down, vice versa. Um, you want to recess that every 5 seconds. And decap BTLS lungs. Anytime you check that, always do decap BTLS. Do you notice paradoxal movement? Which means that it's all moving like it should. If you don't notice paradoxal movement, look for a flailed chest. Maybe a part of the chest is unstable. You can fix that in the field by applying like your hand or a pillow, even a blanket that can apply pressure, and now they're able to breathe a little bit better if it's like a flailed chest, or if they have several ribs that are broken. It just feels better for them. It's all about comfort care, remember? All right, so abdomen injuries. Let's see. The abdomen contains vital organs that require a very high amount of blood, so we potentially could see a lot of bleeding or a lot of internal bleeding if there's uh, a puncture to the abdomen. The blood's got to go somewhere, uh, and it's gonna fill that belly up. So be looking for different sizes of the belly. The organs of the abdomen and the retroperitoneum. Whew, that got me there. Solid organs include the liver, spleen, pancreas, and kidney. So those solid organs are the ones that are not going to have the issues from an explosion. So you have from the should not be affected: liver, spleen, pancreas, kidney. Now, the hollow organs that potentially will have issues are the stomach, large and small intestines, and the urinary bladder. So instead of having to pee, well, you may just busted your bladder and you peed all yourself internal. That's still bad. That's still really bad. And it's going to be painful. So just remember those things. All right. Oh, ow. Sorry. When injuries from the trauma occur in this region of the body, serious and life-threatening problems may occur. Solid organs may tear. You have some fractures. You're gonna have a lot of bleeding now. You're gonna have some big time bleeding. Hollow organs may rupture, poof, done, or leak. That's gross if you think about it. Patients may eventually develop a life-threatening infection. That's nothing that we can do. We can't fix that. We can't handle it. I don't know what you want me to do for that at all, but it's the best that I can do. The rupture of a large blood vessels can cause serious unseen bleeding. We know that. And you always use your decap BTLS mnemonic when assessing the abdomen. If y'all notice, we're going to decap BTLS everything. If y'all can just remember that, it's going to help you at time when it's time for checkoffs. Decap BTLS everything. Scene time. Wait, I'm just going right here. Classification. Is it critical or is it non-critical? Even if it's critical to you and it's not critical to me, but you're the patient provider, then it's critical. It is a critical call to you because you're the one that's providing care. Now, if you happen to run on the same call 5 years down the road and you're more comfortable and more experienced in the field, it may not be to you. Depends on the level of experience that the provider has. That's okay. That's fine. But what I laugh about is people at the hospital always have backup. They just walk in and help you out. But if a medic needs help and they go faster to get to the hospital, oh, that wasn't no big issue. It is to them. It is a time to educate that person and help them get better, not insult them and make them feel worse. All right, so we talked about this. We said it multiple times, as y'all know this. We have two types, ground and air. One gets stopped by red lights, one doesn't. Well, they do fall out of the air every now and then. Some critical care units are also on ground. They may not have that nurse medic treatment, so you would need three on the unit. Uh, I'm just gonna say could be just a driver, could be a basic medic and a nurse, two paramedics and a nurse. It depends on whatever the agency requires. But 90% of the time, your air units will always have a nurse paramedic. Um, One of our trauma centers is also putting PA nurse or a nurse practitioner paramedic. They do it all different. Depends on what shifting they may only use. They may put a nurse practitioner when they're doing just an interfacility transport. I've seen them do way different things. So this one gets a little long, but I'm gonna make sure y'all need to know this because this Association of Air Medical Services, AAMS, and Medevac Foundation internationally identified the following criteria for appropriate use of emergency air medical services for trauma patients. There is an extended period required to extricate or remote a trapped patient. So we know that there's things called golden hour. Uh, you want to get the patient to the facility as fast as you can. If any delayment, the patient becomes critical and it's over an hour transport, that's probably like a 15-minute flight. Send request air support. If the trauma center is more than 25 miles away, call for air. If the patient needs ALS care and there is no ALS ground ambulance a service within they're not around within a reasonable time, traffic conditions or hospital ability make it unlikely that the patient will go to a trauma center via ground ambulance in a decent amount of time, call for air. There are multiple trauma patients who will overwhelm the resources of a nearby trauma center. Maybe that helicopter can fly them to another trauma center a little bit further away. EMS systems require bringing a patient to the nearest hospital rather than bypass facilities to go directly to a trauma center. I don't know about, and I can say this: Central Mississippi says take the patient to the most appropriate facility. I don't know what your local agency says or what they do require you to say to do how to transport. I don't know, but just know you need to know what yours is. Maybe I got that right. All right, so destination selection. So we're going to break down the different facilities. Um, I can speak majority of New Orleans, greater area, probably doesn't have many level one, level two facilities. Um, some of your major metropolitan areas probably don't have level one, level two facilities. Some of your rural areas, that word screws me up all the time because I'm always like rural. Y'all see my face. I'm glad you can't. All right, but here, that's a breakdown of what the facilities have. A level one is the best. Um, Level two is second. Obviously, level one has every bit of capabilities available 24 hours a day for adults and pediatrics. So if it's a heart specialist, they got them for peds and adults. So it's 24 hours a day, 7 days a week. Obviously, most of those are your universities. A level two may not have, let's say, neuro all the time, or they may not have a cardiologist, and they have to send the records to get read elsewhere instead of seeing a cardiologist around the clock. That's the big difference between. Now, there's a whole lot of differences, but that's the easiest way to break it down. We talk about threes and fours. Four is going to be like your rural areas. Um, Level three is a little bit better. Every one of these will all, like the level 4, 3, and sometimes 2 will always transport your traumas to the level 1 facility. So it's just maybe these outer lining communities. I can speak majority of rural Mississippi can't afford some of those, so they may have a level 4, maybe a 3, but your 2s and 1s are majority around your metropolitan area. We only have one level 1 trauma center in the state of Mississippi, and that is in Jackson. It's University of Mississippi Medical Center. The further you go north, we have a level 2 up there. I forgot the name of it. I just went blank. Then you got Memphis, the Med. The further you come south, I think Hattiesburg is a level 2. I don't know about Biloxi in that area, but then obviously everything else can be flown. Um, I know Travis Forest General is a level. They're not a level 1. They may be a level 2 because a lot of their patients will be flown to Jackson for the trauma center. But Mississippi only does have that one level 1 trauma center. It's bad when you need the help, but at least we got one. All right. Trauma centers are guys. Let's see. Um, so when you look at specifically trauma centers related to the pediatric patient, it's very rare that you have a pediatric specific trauma center. You may have those pediatric sources available at your level 1s. So that's the reason why your pediatrics have got to go to the level 1 trauma center, or they're flown outside of the state because they just got to go somewhere that specializes in pediatrics. Do not make the mistake of transporting a pediatric patient to an adult trauma center when a pediatric trauma center is available, because you're gonna look like an idiot, and just because they're gonna tell you just saying. I can't read that. I don't know really what it says. I tried. So the ACS, COT, and the CDC published a field triage scheme. That's what that is. I Googled it earlier and I tried to replace the slide. Mickey, we have a PGR in Lafayette. Now, are they a PEDS trauma center? Or do they just specialize in PEDS? Okay, all right. I did not know that. I'm glad I hear that because I know it's not Lafayette, New Orleans is not far flight, but it's a long ground side if you got to ground them. But most time, Acadian's going to fly them over there. If I'm not mistaken, I think Acadian also has the contract for the PEDS hospital in New Orleans, so they they can also fly out a PEDS specialist for their trauma center. Um, so the criteria is intended to help pre-hospital care providers recognize what type of patients that they have and what best trauma center would fit that particular classification. Um, Management and transport and destination. Just, I hate to say this, but calm down. Take a deep breath, breathe, and then continue to do your job. Um, if you don't do a consistent assessment of a patient, you're going to mess up. You're going to miss something. I'll tell you again, correct the life threatening issues as you come across them. If you walk up and you see squirting blood that is just pumping everything, put your hand on it. Fix that right now. Don't wait till you get to that extremity. Fix it. Once that's under control, start your rapid assessment. Right there, it says never hesitate in ALS backup. I don't know. We in my area we do some basic transfers. Only we are not allowed by the state to run BLS calls. So that's out of the question. But we are allowed them to take out of town transfers and just crap like that. It helps alleviate sending a paramedic on a call that the guy needs to go to the house, but he's bedbound and he doesn't have any, no assessments required, as ALS assessments required. Guys, I'm gonna give 10 minutes real quick. I need to. Got knocked on the door is the reason I gotta go take care of him. Meet y'all back here 8 o'clock, and we'll go over a few more things, and we'll see what other kind of trouble we can get into. See y'all in 10 minutes. My bad. I hit the wrong hit the wrong button. I'm sorry, y'all. Give me a second. And hopefully it'll clear back up. All right. So back to our thing. Never do harm to your patient. Never. Um, you always want to do the best for them. Be their advocate. Always make sure that you have stay up on your certification, stay up on your education. Try to do your best to attend these different EMS synopsis or your EMS conferences. Continue your education, read a lot, give opportunities to grow. Don't just say like, oh well, I did it and one and done. Well, it's like the same thing with CPR. After a while, yes, it is the same, but maybe they've changed your compressions and you need to continue the class and not just make sure that it's a con ed class. Make sure it's something that you get information out of. Um, I don't know how else to put it. Um, so I actually have to go take care of a patient. They're actually sitting behind me, so being super cool. I am going to give y'all so listen to me. When I give you this, I need to explain some things to you. This code will also unlock your test. I have now put a test code on every chapter we go to from now on. This will be only good for the next 5 days, and then the class will lock. So if you do not take it in the next 5 days, your class will lock, and you will have to tell me on Tuesday, the 23rd, why you need back in the class, why you need to take the chapter. And there will be extra work for you guys to do. I would, if at all possible, oh look, I can type tonight. Your code, whoops, is also in the chat. The code for the classes tonight is 7E1Q #. You better write it down because this is the only way that you're going to be able to take your test tonight. So from now on, you may have 2 codes, single code, double codes. I'm not going to tell you all that. So yeah, you can either message me through the Canvas or through Facebook, whichever's easiest to you. Guys, I gotta go take care of this patient. Again, keep this code on you, 7E1Q #. That is your code for the night. Y'all folks have a good evening, and I will see y'all on the flip.